Welcome, everybody, to my presentation on disparities in care in asthma patients. My name is Terrence Shenfield, and I've been an education coordinator for the last 30 years. I am also the co-owner of A&T Respiratory Lectures, so I hope you really enjoy this presentation. It goes a lot into asthma, and it also speaks about the disparities in care, where some people are disproportionately suffering more than others. I want you to pay attention to this graph. This graph lists the patients with their mortality rates for different populations. For example, we have populations of white people, we have populations of black people, we have populations of Hispanic, and we also have populations of Asian patients. It also is broken down into adults and children, and disproportionately, Black Americans suffer from asthma much more, and actually the mortality rates are very high too. So if you compare the Caucasian versus the African American, you could clearly see disproportionately that the mortality rate for Black people is so much higher than white people. And I want to get into a little bit more details why this exists, and we'll understand more as we go along. The objectives of today's presentation is, number one, I'm going to explain exactly what asthma is. Then I'm going to go into some statistics, especially the statistics amongst African Americans. I'm going to talk about risk factors for asthma. I'm going to talk about how socioeconomics impacts asthma mortality. I'll get a little bit more into genetics. I'll talk about environmental factors. And this is kind of odd, but when people report symptoms of asthma, there's actually differences the way people report symptoms. And then I'm going to talk about some solutions. So sit back and let's enjoy this presentation. So exactly what is asthma? Asthma is a disease and it results from the inflammation of the airways. Now, the symptoms and how you could recognize if you have asthma is typically you have chest tightness. Also, you could have some nocturnal wakening at night. You could have wheezing. You could have shortness of breath. You could have a cough. Maybe you can't participate in sports. So a lot of people treat asthma with a bronchodilator like a beta agonist albuterol. And the problem with that, that's only one part of the equation. You really need to get some inhaled corticosteroids on board because that actually decreases the inflammation. Chronic asthma leads into airway remodeling. Airway remodeling is a fixed obstruction of the airway, and it cannot be relieved by any kind of bronchodilator or inhaled steroid. So you really got to get a good handle on it. So what causes asthma? What are some of the well-known causes? Number one, there is a genetic component to asthma. And a lot of people who have moms and dads who have asthma, or uncles and aunts, they could end up getting asthma. There are other reasons why you get asthma. For example, you could be allergic to allergens. Allergens could be dust mites, it could be pollen, it could be cigarette smoke. And some people actually get a asthma attack from diet. Like certain foods you eat can really result in chest tightness. The funny part is I typically don't have asthma, but sometimes certain foods I eat, like I love spicy hot foods, but it seems like every time I eat a hot spicy food, I get a little bit of a wheeze. Also, people who live in the city are actually subjected to pollutants in the air, all the cars, all the emissions of gases, and that could cause asthma. Also, there's a lot of people with asthma who really are typically fine most of the time, but if you happen to get a respiratory infection, say from a cold or a flu, your asthma really flares up. And then there are people who have occupational hazards. For example, my mom worked in a dry cleaning store. So as a result of working in there, she actually inhaled those fumes. I used to come visit her and I would smell these fumes in the air and like I would get chest tightness. So certain people work in certain occupations and they don't have good air exchange and they get asthma. They've shown that people who have atopic dermatitis, such as eczema, are predisposed to asthma. It also could be caused by emotional stress, and some real recent studies have shown how obesity actually increases the likelihood of asthma. So there are many different reasons for it, and the idea is, how do you manage it? How do you avoid these allergens? What can you do to make yourself better? So let's talk about asthma prevalence. When I'm talking about asthma prevalence, I'm talking about hospitalization rates and mortality. And disproportionately amongst the African American children, the rate of hospitalizations, the rate of mortality is much, much higher. So you say, what's going on? Is it genetic? And evidence has shown it has a lot to do with socioeconomics. What I mean by that is a lot of African American children live in the city. As a result of living in the city and being socioeconomically deprived, they end up going to clinics instead of a primary care physician. Because they go to a clinic and they can be seen by different physicians each time, there's no continuity of care. As a result of that, they don't have great care or management of their asthma. Asthma management has a lot to do with education. So the people taking care of these children, their parents, their caregivers, need to be really versed and understanding exactly how to manage asthma. So if your asthma gets worse, you need to be able to updose your medications. If it gets better, you could go back off again. So the idea is these children are not being managed properly. And also, when they do go to the physician, they see a different physician. And also, you think about the inconvenience of sometimes taking public transportation. Like, if your kid has an asthma attack and you got to get on a bus and then you got to walk 5 blocks, that's a lot different. I know me, if I really needed to access my primary care physician, which I have one physician because I got good insurance, all I need to do is call, make an appointment. I jump in my car and I go see the same doctor who knows me so well. So these are some of the issues going along with asthma prevalence, hospitalization rates, and mortality, which is very important to understand. Let's talk about some asthma data and statistics. This was brought forth by the Office of Minority Health from the U.S. Department of Health and Human Services. Data has shown that 3.9 million African Americans reported they currently have asthma. They are 3 times more likely to die from an asthma attack, so versus a white person or a Hispanic person. Their use of the emergency department is 260% higher. They have a 250% higher rate of hospitalization admissions. They have a 500% higher death rate from asthma as compared to white children. And African American women were 30% more likely to have asthma than white women. So statistically, all of these numbers are really troubling, and you wonder why. Why is this happening? Like I said before, the genetics really don't have a lot to do with it. If you're predisposed, I don't care if you're white, black, Hispanic, Asian, if your parents have it and your mom had it, your dad had it, genetically you're predisposed. But a lot of evidence has shown that it has a lot to do with socioeconomics, where you live, what kind of living conditions, access to health care, access to a primary care physician. So all of these factors add up. But the results are the results, and this is very troublesome data. As asthma educators and respiratory therapists and nurses, we really need to understand and teach how asthma works. And in asthma, there's 2 important factors. One is called asthma severity, and the other one is called asthma control. Each is different, but each works with them together. So let me just say, you have a child and they have symptoms of asthma. So what you need to do is you need to take them to a doctor and you need to determine their asthma severity. And what do I mean by asthma severity? Basically, you are going to do a history on them. You might do some spirometry if they're greater than 5. You might be looking at the history of what the parents say or the caregiver says. And based upon your severity level, when you first meet the doctor, that will determine your asthma severity. And in regard to asthma severity, there are 4 different categories. One is called intermittent. The other one is called persistent mild. The third one is called persistent moderate. And the fourth one is called persistent severe. So based upon the severity of your asthma, we will classify you in this category. Once you get this initial category, in other words, when you come to the doctor for the first time and you're diagnosed, they are going to put you in a category, and based upon that category is where your treatment plans are. So obviously, if you're intermittent, they might just say, which I'm going to get a little bit more detail later. Intermittent, maybe you could just be managed by a bronchodilator, once a day. You get a little short of breath and you take a couple of puffs of your albuterol and you're fine. But when you get into moderate and severe asthma, you really need to be managed with much more medications than just bronchodilator. So you go to the doctor, they do an evaluation of you, they ask a history of you, and they give you a diagnosis. And based upon that diagnosis, this is where you are. So you don't switch back and forth. If you're diagnosed as persistent moderate, that's where you are, and that's where your treatment plans are. But you can up and down the medications based upon that. So we now know what asthma severity is. You need to be determined by the doctor, and this is done on your initial meeting with the doctor. The second thing, once you have a severity level, you need to get medications to keep you under control, and this is what we call asthma control. What that means is that during the first time you're diagnosed, for the first 2 to 6 weeks, you may go back and forth to the doctor because they want to see if your asthma is being managed, and they could up your medication or down your medications. So once you get in control and your pulmonary function is good and your spirometry is good and your peak flows are good and your symptoms are good, you are in control, and that's called asthma control. And then at that point, all you need to do is see your doctor like once every 6 months, for your asthma. Also, you'll learn that once you are under asthma control, sometimes you will have a flare-up. And if you have a flare-up, you need to increase your medications to control your asthma. So asthma severity is at the beginning when you first meet the doctor, understanding what level you are. Asthma control is after you've been diagnosed, after you're given medications. You want to make sure that you don't have the symptoms that would put you back in the hospital. These 2 major things are very, very important with asthma patients. I wanted to share with you 4 different charts. And these charts were adapted from the National Asthma Education and Prevention Program, which is part of the NIH. And they talk about classifying severity, and they talk about initiating treatment. Now, what that means is, remember I told you before in the last slide that you are classified into a severity level such as intermittent, mild, mild persistent, and severe persistent. So on the left-hand side, you could see these different categories like intermittent, mild, moderate, and persistent. Notice on the right-hand side, you're going to get the preferred treatment option. So right here is your treatment plan. So you're classified in one of these categories once. That's where you're identified. And here it's going to list the symptoms. If you were classified as mild persistent, and remember this chart right here is for children 0 to 4. This is for 0 to 4 years old, and I'm going to show you other charts. So you're diagnosed with mild persistent. When you are under 4 years of age, or 4 years and under, they cannot do spirometry. So they base it on symptoms. And basically what this means that you have asthma symptoms 3 to 6 days a week. You also wake up at night 1 to 2 times a night. Does it interfere with your normal activity? minor limitation. So you get some minor limitation. And when they talk about risk, risk means how many times have you been admitted to the hospital. And if you've been admitted for greater than 4 times a year, then you have been actually diagnosed for mild persistent. So that's your category. The treatment plan for mild persistent is low dose inhaled corticosteroids, probably with a beta agonist too. So based upon your severity level, based upon your symptoms, based upon does it interfere with your normal activity, also your risk, this is your treatment plan. So this is how you classify asthma, and this is how you initiate treatment plans. This particular graph we're looking at is for children 0 to 4 years old, and I'm going to show you another graph in a second. Okay, so now this graph, which is very similar to the last one, the only difference with this is we're talking for children 5 to 11 years old, right? Now, the difference between under 5 and over 5 is you could do spirometry. So you notice now we got pulmonary function right here, right? So you could do spirometry testing. So again, the severity category is the same: intermittent, mild, moderate, and severe, based upon the symptoms, which are very similar. So right now, let's say you're intermittent. So you're 7 years old and you're intermittent right here. You're intermittent, right? So what you want to do, you have symptoms less than 2 days a week, and then you have symptoms less than 2 times a month. Do you have any kind of impairment to play any sports? None. You could do everything you want to do. You do spirometry, and your spirometry levels are perfectly normal. Your FEV1 is greater than 80%. Your FEV1 over FVC is greater than 85%. And do you get admitted to the hospital or the emergency room? Maybe 0 to 1 times a year. So basically, you get a little wheezy less than 2 days a week. You wake up at night only 2 times a month. And what you could be managed with is a short-acting bronchodilator. So you could actually give this patient a albuterol treatment as they need it. So based upon this severity category, which is strictly for ages 5 to 11, you could titrate the medications based on. So we're classifying the severity and we're initiating the treatment. So this is what I want. And we got 2 more graphs to go. Now we're talking about a youth anywhere from 12 years of age and older. So basically, this is the category right here. So this includes adults. So again, the commonality, remember, this is measuring severity. The commonalities, you got severe persistent, you got moderate persistent, you got mild persistent, you got intermittent. Because they are greater than 12 years of age, you can do pulmonary function. So the pulmonary function values are here. Notice as the severity increases, so does the severity of your pulmonary function test. So this is a very easy way to quantify how sick you are. So let's work in a patient who is now severely persistent. So this is this category right on top. What happens? Every day they got symptoms all through the day. They also have symptoms at night. They wake up coughing, everything. How about their impairment? Can they engage in any kind of sport? Absolutely not. They're extremely limited in their sport. Then they do the pulmonary function. Your FEV1 is less than 60%. Your FEV1 over FVC is reduced. And also, when you talk about exasperations, they are actually admitted to the emergency room or go into, for some reason, at least twice a year. So if your initial diagnosis is severe persistent, and this is your initial diagnosis, you are going to be given medications to manage yourself. And as you can see, the preferred treatment all the way on the right is a step 5. So a step 5 is high dose inhaled corticosteroid, long acting beta agonist. Also, you might want to consider a short dose of oral corticosteroids. You also have your medium dose there, like a step 4. I wanted to bring your attention to the step 5 and step 4 and step 3. You notice how we have different steps when we go from moderate persistent to severe persistent. And basically, when you're diagnosed with asthma, and we classify your severity score, which is very important, and then we start you on a preferred treatment plan, you might have exacerbations. So what you do is you increase your medication. So you'll go from a step 4 to a step 5. So, and then once you're managed very well, you could go back to a step 4. So this is how it works. When you really classify the severity of asthma, they come up with a treatment plan. And the ultimate goal is that you can do everything you normally do and you have no symptoms and you're managed very well. And we're going to get a little bit more onto that in the next slide. Now, this is a very important slide. This is different than the last slides you saw. Now that you've been diagnosed with your severity score and you've been given medication, the question is, are you under control? So the ultimate goal is to be well controlled. In other words, the medications you take based upon your severity score, you are well controlled. How do I identify well controlled? I identify well controlled that you have less than 2 times a week symptoms right here. I say well controlled is that you have 0 to 1 occurrences at night. You might just wake up once during the night or none. I also know that your FEV1 is greater than 80%. Your FEV1 to FC ratio is greater than 80%. Your exacerbations, how many times do you have to go to the emergency room or something, is less than 0 to 1 time. And what that means is you are really managing the severity of your asthma, and you determine your severity score upon the previous scores that I showed you before. And the point is, you want to be well controlled. If you are well controlled, you're not going to be admitted to the hospital. The likelihood of you dying from a severe asthma attack is very low. This is the problem with people. People don't control their asthma. They get better for a couple of days and they stop their medication. Also, you have 2 other categories. Remember, the gold standard is you want to be well controlled. That means whatever treatment management the doctor orders, you must maintain. Now, if you are not well controlled, that's a whole different category, and so is very poor control. Most people who are admitted to the hospital are not well controlled. They are in the category of this one or this one. This is where they lie. And look at the symptoms. So you're not well controlled. That means you have daily symptoms greater than 2 times a week, at least 2 times a night. Your FEV1 goes down to 60 to 80%. Your FEV1 to FVC ratio is 75 to 80. And this is what happens. So this category right here, the top category in yellow, is for children 0 to 11 years old. And this one is for adults 12 to adulthood. So the point, what I'm trying to say is, this, asthma can be well controlled. You see a doctor, you get the medications, he follows you up or she follows you up over a few weeks to see if you're well controlled. And if you're well controlled, you are in a good place. When you start going into not well controlled or very poor controlled, you need to consider stepping up your medications. Like I showed you in the previous slide, when you go from step 4 to step 5 or down to step 3, you need to be able to titrate your medications so that you get back into the well-controlled category. This is the whole concept of managing asthma. This is the reason why so many people get admitted to the emergency room, and this is the reason why so many people die, because they don't follow their asthma control policy. They don't follow what medications they need. A lot of them stop taking the medication. They feel better, and then they stop, and all of a sudden the airways are all inflamed, and now they're not well controlled. And so the idea is, once you develop you have a routine, you have some certain medications you need to take, continue to take it. So let's talk about the role of socioeconomics and asthma severity. As you could clearly see on the graph on the right, that regrettably, Hispanics, African Americans are disproportionately suffer more from economic hardship than other groups, especially the white groups. So a lot of the results of this is that you have to live in low income households. So when you don't have a lot of money and you live in a household that is, you rent some property or you rent a house or an apartment, whatever you have, a lot of times you got higher levels of indoor allergens in these. And for example, you could have cockroaches, you could have dust mites, you could have mold. You may have carpeting that you can't afford to rip up. One of the most common things any kind of allergist will tell you, you got carpeting at home, rip up that carpeting and put some hardwood floors or some linoleum, because that harbors all these dust mites and mold. Also, low income neighborhoods have poor housing. A lot of times they don't have HEPA filters in the heating system. They have other environmental issues going on. And also there's a lot of stress. When you live in an urban environment and you have a lot of crime in the area, a lot of times you're afraid to take your child out to the doctor. So, here you got your kid and you need to sort of, bring him to the doctor, but, you're hearing about some gunshots outside or you're hearing something like that. So a lot of times you take public transportation, but you're so afraid to go outside that you miss appointments. And remember, I was telling you before, sometimes most of these patients are treated by clinics rather than a primary care physician, which represents a real problem because you don't have the same doctor actually reviewing your child day in and day out. So they get to know your child, they get to know all the levels, they get to know you. And this really impacts the care. So socioeconomics has a big impact on asthma management. You may be asking, what's the role of genetics in asthma? Genetics can predispose you to a bunch of different type of illnesses, such as hypertension, diabetes, obesity, and yes, there are links between your allergies and asthma. Typically, you are 6 times more likely to have asthma if any of your family have it. And a lot of times, even if you are genetically predisposed to asthma, you really need to manage it. Like I was telling you about controlling your asthma and determining your level of severity. Yes, you might be predisposed. Yes, you might have asthma, but you really got to manage yourself. You can't change your genes. So yes, there is research that genetics have a lot to do with it, but I would not say this is predominantly a African American thing or an Asian thing or a white thing or Hispanic thing. It all depends on where's your gene pool. Because of socioeconomics and because you might live in an apartment building or you might live in a multi-housing unit in the urban development, sometimes you smoke at home. And they did some studies looking at secondhand smoke at home, and they were looking at the prevalence of secondhand smoke amongst African Americans. And they found that almost 20% of them smoked at home. They also did some studies where they looked at if you have the higher your education, the less smoking you do at home. Actually, the less smoking you do all around. So education has a relationship to smoking, especially smoking at home. So the best thing to do is to smoke outside. And I realize this could be a challenge. Who wants to go down 3 floors and go outside to smoke a cigarette? They say they rather smoke in the next room and keep the door open. So really the best thing to do, especially if your child or any household member has asthma, is don't smoke in the house. So what role does air pollution have with asthma? And there's definitely a correlation between particulate matter, carbon monoxide, ozone, and sulfur dioxide, which is typically found in urban developments, especially with those with a lot of traffic. So Air pollution in the urban community is very high because you got all those trucks and cars and everyone's in a small area. Another concern is stress and comorbidities. They found that, a lot of times in urban communities, there's violence, and this has caused stress to family members and so on. Also, there's a higher level of obesity in the African American community. So these are two of the risk factors, that goes along with asthma and especially managing your asthma. As I was saying throughout this lecture, many of us are fortunate to have health insurance. Like I have a PPO, I have Aetna PPO. I have a primary care physician who's known me for a number of years. He knows everything about me. He knows, whether I'm good or bad, and typically I try to be good. But when you are in an urban development and you are socioeconomically deprived and you cannot have a primary care physician, you end up actually seeing a clinic. And when you see a clinic, it's typically you may not see the same doctor there all the time. So you get this mixed of appointments with different people. As a result of that, you really don't get continuity of care. So studies have shown that a lot of African Americans who don't have insurance use the emergency room as their primary care. Another thing that's found is they use inhaled bronchodilators as their level of care. So in other words, you're diagnosed with moderate persistent asthma. They told you to take inhaled corticosteroids as well as albuterol, and you end up just dropping the inhaled corticosteroids and you just do the albuterol, and what happens is you get all this inflammation. So don't ever use inhaled bronchodilators as a controller. There's a difference between a rescue medication and a controller medication. A lot of times, like I said, you really need to sort of see the same physician so you get continuity of care because they can manage your asthma a little bit better. This slide speaks about communication between the patient and the physician. And it's been shown, studies have demonstrated that healthcare providers frequently underestimate the severity of symptoms. So you say to yourself, why are they not getting it? And there's a couple of reasons why. Number one, it could be a caregiver factor, which means it could be your parent, your grandmother, who's actually explaining to the physician the symptoms that the patient has. And sometimes it could be based on literacy. Like if you don't have a good education and a good understanding of asthma and FEV1s and shortness of breath, and you just like sort of don't use the right words, physicians don't understand. And sometimes they could all talk about, how you describe the words with, different words, like, oh, every time he gets a cold, he gets asthma. That's not really a good definition. And also, you got to think about physician factors. Physician factors are some physicians, because of time restraints, don't really get a full history of the patient. They sometimes don't really understand a patient's cultural and educational context. So when they're talking to somebody and they're talking about the symptoms, they don't take into account that they may know nothing about asthma. A lot of times, 1/3 of patients who did not take their controller medication because of their health beliefs. A lot of people don't believe that inhaled corticosteroids should be taken every day. They feel like, oh, if you get better, you get better. You only take that when you're sick. They don't realize that inhaled corticosteroids is a controller medication. And some people just don't understand cultural communication. I think a lot of physicians should be, culturally aware that different words are used, different mannerisms are used, and you really need to have a cultural understanding of the people you're working with. Everyone has a different culture, and you really have to be understanding of all cultures and how they talk and how they express themselves to really get a good understanding of everything. They did some studies where they were looking at the language between the physician and the African community caregiver. So the caregiver is the mom, the dad, the aunt, or the grandmother, whoever's taking the child to the doctor. And what happens is they describe asthma symptoms differently. For example, the concept of FEV1 or peak flow is typically not used. Now, this is when we as healthcare practitioners are dropping the ball. We should educate all patients, all family members on understanding what an FEV1 is and what a peak flow is, so you really understand that. When you talk about nocturnal asthma symptoms, nocturnal asthma, instead of saying nocturnal asthma symptoms, they should say, do you wake up in the night coughing? Do you ever times wake up like and you're really short of breath? So, talking and understanding what people say and what they mean is really difficult, but you really got to get a good point to get the point across. For example, dyspnea. We all know what dyspnea is, like shortness of breath, but a lot of people don't use that term. We don't, every time you're short of breath, I don't say I'm dyspnic, so you really got to understand. Chest tightness is a common word to use. A lot of times they underestimate the severity of asthma. What I mean by that is one of the most objective ways to measure your asthma severity is to do a peak flow. And a peak flow can almost give you a numerical value if you're good, bad, or if you're sick. So sometimes if you say I feel a little tight, maybe if I take a hot shower, I'll feel better, or maybe if I have a cup of tea, I'll feel better. You really have to educate people to understand exactly the severity of their asthma, and you have to be able to educate them to a point where they can communicate with you so you understand it. So this is a two-way communication between the physician and the caregiver. So now that we know what the problem is and we know some of the issues with it, let's come up with some good solutions. Now, we're not coming up with these solutions for the first time. There's some really good platforms put in place to help with this issue. So what role do you think school-based asthma programs plays in the management of asthma? I think it has a very, very important role. Actually, when you think about the school nurse, it can really improve a lot of programs, especially with education. If you really educate your students on how to use a peak flow, how to describe severity, how to really manage and educate them that there is such a thing as a rescue medication and a control medication, you really can benefit the patient. If you really think about it, because a lot of these students have poor access to health care, some of the best education could be done at school. And so this actually improves the outcomes of a lot of patients who have asthma, because teach the children and they'll understand. This was a very good program that they did in Michigan. It's called the Healthy Homes University Program. And basically what they did is parents who came in with children with asthma, they ended up doing some education for them. And it was a 6-month program. So what they would do is they would go to the house and they would give them education on furnace filter replacements, cleaning, vacuuming the HEPA filters, also how to reduce asthma triggers. They taught the family a lot of information on how to protect the environment at home. Also, they did a ton of patient-parent education where they taught them about severity levels, the difference between a controller medication and a rescue medication, and how to sort of up your medication regimen if you started having symptoms, how to be well controlled, how to use peak flows. They did all of these positive things. What happens is it ended up being resulted in 50% reduction in asthma-related symptoms. They had 3 times more likely to have their asthma under control. There were less visits to the emergency department, and the caregivers, the parents and the family members felt so good about everything. They didn't feel so helpless. They didn't feel frustrated. They felt like they could really take care of their children. And when you get that kind of result, it really goes a long way, and they share this information with other families. This was another program they did in urban America. They looked at some city dwellings where there was a lot of cases of asthma and emergency room use. So they created a survey called the Easy Breathing Survey. And basically they asked 4 validated questions, and based upon these questions they created an asthma treatment plan. So I'm going to tell you on the next slide what those 4 questions are, but for this slide let's talk about it. So number 1, the 4 questions talked about asthma symptoms in the previous 12 months. They talked about nocturnal cough, which is coughing at night. They talk about exercise-related symptoms, and they also talk about the duration of cough and colds. So based upon this survey, the physician determined the severity and then created a control plan on giving the proper medications. And the results of this was very good. Actually, hospitalization rates decreased by 53% for Black children and 33% for Hispanic children. The ED visits were decreased. Outpatient visits were decreased for both communities. And what happened was, very interestingly, inhaled corticosteroids prescription rates increased. So what that meant was that families managed the asthma with their family members with inhaled corticosteroids rather than albuterol. So that's really positive results. And now I'm going to show you the 4 questions. So these were the 4 questions. Has your child had any wheezing or whistling in the chest at any time in the last 12 months? Has your child awakened at night because of coughing in the last 12 months? Has your child had coughing, wheezing, shortness of breath with exercise or activity and had to stop because of the symptoms at any time? When your child has a cold, does the cough usually last more than 10 days? So these simple 4 questions, which are validated, they use on a bunch of different patients, let the physician decide the severity of the asthma and then come up with a treatment plan, and it really worked out quite positively. This is another example of a great program. It's called Parent Mentors. And what that did was it educated parents who have children with asthma. And once those parents became really good at understanding asthma and managing their children, they became mentors to other parents. So basically, they would meet with other family members who had asthma, not family members, but other people in the community who had asthma. They would meet them at community sites. They would do phone calls. They would also make home visits. And they really measured 10 different asthma outcomes, and costs were monitored for 1 year. And the result of this was the children who underwent the intervention experienced significantly reduced rapid breathing episodes, asthma exacerbations, and ED visits. So this is a great program. You have parents who have children with asthma. They're doing a great job of managing their children, and they become mentors to other people, and it's a win-win. Everybody wins with this kind of environment. I think this should be done more often. In the city of Philadelphia, they came up with a plan. They had a lot of children who had childhood asthma who were really, coming to the emergency room more than needed. And what they did, they created this thing called the Philadelphia Allies Against Asthma. And they developed a phone line, which basically was a hotline. And what they would do is they would do education on this hotline, and they would do follow-up phone calls about appointments with doctors, making sure that the prescriptions are filled. So in other words, they were keeping whether the parents were compliant in treating their children. And what they found with this coalition was that there were less emergency room visits. They were more likely to attend physician follow-up visits, and also the use of inhaled corticosteroids went up. So I guess the simple thing of calling somebody and sort of getting back to them and following up with somebody is a very good thing. And this is what they did in Philadelphia. As I was mentioning in the previous slides, I was talking to a lot of providers, a lot of doctors and nurses, practitioners who treat patients with asthma really are not very careful about how to ask the right questions and understanding racial ethnic disparities in healthcare. So what they did was they integrated a cross-cultural education for healthcare practitioners to understand how to communicate better with family members and actually get better information going backwards and forwards. So They actually did some education with physicians, and actually this improved the communication skills between the family members and the physician, and this resulted in better outcomes. So everyone could benefit from a little cultural understanding of each party. So I want to thank you for joining me. In summary, the prevalence of and severity of asthma in African American children is alarming. The stats speak for themselves. And really some kind of intervention's got to be done, which I explained throughout this presentation. I think the most important thing you could do is educate. I think you need to educate the parent, you need to educate the physician, you need to educate the child. They got to understand the severity of their asthma. They have to understand the concept of having well-controlled asthma. Another very important factor is school. I love those school, home, and community-based programs because they really did work. Environmental practices are key too, but that's a very much of a challenge because how many people can afford to rip up their carpeting and put in hardwood floors, or how many people can afford to change a new exhaust system into the house and put in HEPA filters? So, there are environmental challenges, and also, like I said, public transportation to go see your primary care physician. Patients who don't have health insurance like you and I, they need to actually access a clinic, and this kind of things actually works out negatively for the management of asthma. Well, thank you very much for joining me. Again, this is Terrence Shenfield, and if you have any questions on this topic, this is a time to ask. And I really thank you for joining my presentation. Some additional references if you need it. They're right here, and if you know anyone with asthma, hope you took some good notes today. This is a continuation of references that might help you, and you have a great day.